Good morning, or yes, good morning, everyone. Thank you so much for joining us. We'll let folks get settled in and we will be starting momentarily. All right, welcome. Thank you all for joining us for our Substance Use and Adolescent Development Risk, Impact, and Strategies for Prevention and Intervention. The views expressed in this training are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. A few housekeeping items for you all. If you are having any technical issues, please individually message me, Alyssa Kuala, and I would be happy to assist you. Any questions for the speaker, please use the Q&A section of your toolbar, and we will try our best to answer all your questions as time allows. If captions or the live transcript would be helpful, please locate that option using your Zoom toolbar. You will be redirected to a very short survey at the end of today's presentation, and we would greatly appreciate it if you could fill that out. Certificates of attendance will be sent out via email to all who attended today's session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube channel, and our Spotify channel. I am super excited to hand this over to our presenter, Carmela DeCandia. Thank you so much for being here today.
Excuse me. Hello, everyone. It is nice to know you're out there. And I'm glad that you decided to attend today. So let me share my screen. Hopefully you are seeing that okay. Let me just get a little bit set up here. 1 second. There we go.
It looks good.
Okay. Great. Someone is saying they can't hear or see anything. I'll let you guys deal with the chat. Well, my name is Dr. Carmela DeCandia. I'm really excited to be here with you to talk about this topic today. I am, just for your background purposes, I'm a clinical psychologist by training. I do neuropsychological testing, so I've been very involved in doing a lot of neurodevelopment work, looking at how kids' brains develop and the effect of different types of adversity on the developing brains of children and adolescents. So my clinical practice is for neuropsych testing, but I have worked in the field for many, many years in child welfare, in homeless shelters, running programs. I've been everything from a staff member to an overnight staff and eventually running programs and a psychologist. So whatever role you are out there, I may have had that same role. And I know what it's like to work on the front lines in community settings. But also as well as in private type practices where I am now. I'm also a faculty member at Boston College and Boston University, where I teach neuroscience for mental health counselors. I teach counseling addictions. I'm actually teaching that class right now for master's students. And I teach a variety of other classes around psychological testing and lifespan development. And I do have a small business, Artemis Associates. You can find that at artemisassociates.com and learn more about me there. That's more for training and consultation regarding issues with high-risk families, becoming trauma-informed, and helping agencies develop staffing capacities. So we do lots and lots of training out of Artemis Associates. So today we're going to focus on substance use in adolescence. And understanding the risk factors and how this develops, but really do a big focus on what it's doing to kids. And then being able to kind of talk about some treatment strategies. So I hope by the end of today, people have a good understanding of how substances actually do affect adolescent development, understanding how to kind of screen, assess, and think about what type of evidence-based treatments to use. Knowing about the difference of comorbid conditions. It's really important to think about comorbidity with mental health and substance use because I think there's an incredible amount of overlap, and having some strategies to work with kids and families. So the way we'll, excuse me, the way we'll structure things today is first we'll talk about prevalence and comorbidity. We'll do a big bulk on the middle two bullets, as I said, about the brain and development of addiction and its impact, and then we'll wrap up with strategies. So, prevalence of substance use. What can I say? It's a lot, right? There's a lot of statistics out there, but we certainly know that I mean, there's a good news and bad news story. Let's kind of put it that way. But there is a high prevalence of use and impact for teens. Though when you're thinking about kids, you do have to kind of think about age groups because it can really vary quite a bit. And so we want to kind of think about teens as younger teens, middle teens, and older teens going into young adulthood. But as you can see from the chart here and the graphic, addiction is a significant public health problem. It takes a toll on society. It costs us a lot. Drug overdoses are quite high, nearing 1 million people as of 2020. And half of people 12 and older have used an illicit drug at some point in time. When we're talking about drugs, we are talking about nicotine and cigarettes as well as illegal drugs and alcohol. So there's a lot of different kind of pieces to this problem. Men do tend to use more than women in terms of illicit drug use and higher rates of alcohol-related hospitalizations. But women also have a very high use, and there's a lot of overlap in terms of different ways to work from a gender perspective in that way. And you'll see from the bottom bullet there that those who identify as LGBTQ experience a very, very high percentage in comparison. So there's a lot of other types of stress that are affecting this particular group that lead to a high use. As of 2024, we saw the rate of overall substance use disorder reaching almost 50%, and alcohol use disorder being close to a third, with drug use disorder being slightly less. And illicit drug use really is becoming the biggest issue. You can see from that graph. That's one of the things that we really have to watch for. As I said, it is a good news, bad news story. The good news is that a lot of substance use is down there are trends that have gone down. Despite the high use, it has trended down since, the 70s and 80s. So most adolescents did not use substances in the past year. 73% between ages 12 and 17 reported no use of alcohol, marijuana, nicotine, or illicit drugs in 2023. This is a good news story. That means public health approaches and kind of social understanding of drugs and alcohol for teens has made an impact in terms of usage. So overall, most use has remained low among the 8th to 12th grade level, and that's a good news story. Unfortunately, there is still a lot of use in the remaining population, and we have about 8.5% of 12 to 17-year-olds that actually meet full criteria for a substance use disorder. And young adults, it's about 27%, so the 18 to 25 group. So we're still kind of at that. I mean, we're not at 50%, but somewhere in the, 20% of young adults and 8 to 10%, depending on the age range, you can see quite a bit of full-blown substance use disorder. So these are the kids we want to understand, we want to get to, we want to understand what risks are happening to try to help this particular group. If we break it down by the type of substance, you can see that alcohol is the most commonly used substance among teenagers. 19% of 14 and 15-year-olds, 5 million children between 12 and 20 have reported alcohol use. Binge drinking at least once in the past month, about 3 million. And you can see from the different age ranges and grades how much alcohol use in the last year based on grades. And obviously it starts lower in 8th grade, but it really is peaking. So alcohol probably is the biggest thing, which is always interesting because people think about drugs and illegal drugs and worry about that. But, alcohol is part of society. It's available. And there's a lot of more acceptance of alcohol use, and seems to be the issue that we have to really be careful of with our teens. In addition, nicotine and vaping are significant problems. And that remains kind of the dominant use among teenagers, 8th grade to 12th grade, anywhere from almost 10% to 20 odd percent. And tobacco use through vaping seems to be the biggest issue. I'm sure that there are people out there that are working with youth and hearing it, and people have the misconception that vaping is somehow safer and different. But if you're using nicotine, you're using nicotine. And one of the things about nicotine, I was just teaching this in my class, is that nicotine binds to acetylcholine receptors in our brains. And acetylcholine is a neurotransmitter that affects our memory and various other parts of our brain. You see acetylcholine in memory disorders and things like Alzheimer's. So, when you think about nicotine mimics acetylcholine in terms of binding. And so it can bind to those very same receptors. There are acetylcholine receptors everywhere in your brain, your prefrontal cortex, your limbic system, your brainstem area, the inner parts of the mesolimbic system where it's memory based. Nicotine is affecting every part of our brain, and in part, a lot in the middle part of your brain, which is the reward system of the brain, called the ventral tegmental area. And in that system of the brain, there's a lot of acetylcholine receptors as well. So nicotine is getting into our brains and affecting the developing brain. And as we'll see, a chemical that is affecting your brain over time as you're developing literally changes the brain because it's still developing. So nicotine is very, very big deal, as is marijuana, which also binds to many, many parts of your brain. Movement coordination centers, thinking centers, memory centers. You can think of all the kind of signs and symptoms of being high from marijuana. It's affecting the brain in many, many ways. So I want to kind of zero in on marijuana for a second because it is the most common. It's thought to be the most common. A lot of teens are not smoking pot. And so the use over the decades has gone down, but it is still a very risky drug, despite the fact that it has been legalized in most, if not all places. And people don't think of it as a problem. They kind of think of it like alcohol, like it's not a problem. I think people think alcohol is worse. And I've had these debates with my students. It'd be really interesting for you to think about that. Feel free to put comments in the chat if you want to. Is marijuana as dangerous as alcohol? Is it considered dangerous? Should we even be using the word dangerous? When you understand the effects of marijuana on the developing brain, then you start asking a more nuanced question. Is it dangerous, and for whom? Because for many people, it may not be. And certainly there's different methods, edibles versus smoking. So there are different methods there, but marijuana for young brains, and when I say young brains, I'm talking 16 and younger. So, that brain is highly plastic. It is very much in a state of flux with puberty happening. And so the effect of drugs on the developing brain at that age, the adolescent age, up and I would say before 18, can have a very significant effect that in some ways may be, in some cases, irreversible, depending on how heavy smoker you are. You see from these risks on this slide that for these younger brains, heavy use, so kids who are smoking several times a week to daily, there is a significant impact. There is a decrease in fertility because of the effect of our reproductive hormones. There tends to be an increase in depressive symptoms and an increase in impulsive symptoms after due to heavy use over a period of time. 60% of kids who do smoke daily, there's a lower rate of graduating from school. And two of the things that really stand out to me the most is the increased risk of having a psychotic episode, as well as 7 times more likely to attempt suicide. Those two things really stand out. I have seen adolescents that I've seen in my clinical testing practice where there was questions of whether maybe there was a psychotic disorder happening, whether there was an emerging schizophrenia possibly happening because they were having these psychotic episodes. And it was really became pretty clear that it was secondary to a cannabis related disorder. And that was the treatment that needed to happen. This child, I think he was 17, also had suicidal ideation and quite a high bit of depression, and he was struggling in school, executive functioning kind of things. So these risk factors are pretty much a pretty significant thing. And the question then becomes, how do you get young people to stop? Because if you just tell them to stop, that's not the way young brains work, right? They're not just going to stop. And education sometimes isn't the thing that affects young people because they think they're invulnerable. If we could get them not to delay, if you could think about it from the point of view as not doing it when you're young and your brain is so vulnerable, waiting till your brain is a little more adult so that it's less vulnerable, that may be a different conversation. But that's essentially the issue. It does make you think. I saw Erica's comment about legalization and how safe, and it definitely has an impact on public perception for sure of what is safe and what is not safe, and culturally. So the science is there in terms of the effects, but how that's caught up to kind of a cultural understanding, to me, it's not something I've seen. I don't know about marijuana use more through vaping than traditional smoking through youth. Probably both. Vaping is considered kind of the thing that most teens go to. When you're thinking about all these different substance use related disorders, and I just highlighted a couple, excuse me. We're also thinking about mental health. And so one of the things we have to think about is substance use with a mental health disorder, substance use without a mental health disorder. That becomes very, very important in terms of assessment and treatment. So I want to get to that in a second, but if you want to just look at this slide, you're kind of seeing that there are disparities. There are disparities, racial disparities, in terms of use with and without mental disorder, where you see multiracial youth having the highest prevalence of substance use disorder and co-occurring major depression. Then white adolescents versus Hispanic adolescents having higher rates, and Black and Asian slightly lower, males higher than female. And interestingly, Black and Hispanic, similar to mental health treatment, less likely to receive treatment than whites than with or without substance use or mental health disorder. So obviously, the impact of discrimination and cultural pressures also are having an impact, and we have to keep an eye out for watching for which kids are at the most risk in what communities that you're working in. So let's talk a little bit about comorbidity and thinking about the kind of things that are kind of facing the youth of today. Before I switch the slide there, I wonder if people want to write into the chat, like, what are the pressures that are facing the youth of today that might be different than the youth of, say, 10, 20 years ago? When I think about my growing up in, the 80s, there were very different pressures. And look at all the social medias coming up on the chat, right? Technology, social media, climate change, 24/7 technology, absolutely. It's the number one thing that's coming up, and there is this constant pressure going on, not just political, but even the academic pressures. Don't you feel like they're in some ways somehow greater? Or different? I'm not sure if it's greater or different, but there is a different kind of pressure that is affecting our youth of today. Achievement pressures, getting into colleges, which is becoming so hard, financial pressures to be able to do those kind of things, economic uncertainty because of the way of the world is functioning, particularly right now, and cost of living increases that make young people kind of, especially younger adults, looking into the future, wondering what they can and be able to do. Safety. I did not grow up at a time where school shootings were happening all the time. I think there was one that just happened in Canada. It was on the news just like 10 minutes ago. And it's just constant that kids are going to school constantly thinking about this. Identity challenges and being accepted. In some ways, there's somewhat more of an openness than, say, 30 years ago when I was young. And then in other ways, there's not. There's a backlash. There's more, just not more discrimination, but a different reason of discrimination happening. So it's a little of both and going on. Family stressors, burnout, sleep issues because of the pressures. I see a lot of kids who, really good kids, but they are working jobs and they are trying to manage homework loads and extracurriculars to get into a school or get a scholarship that is high competition. So there's a lot and a lot of social media pressure as well. About a quarter of teens are faced with a mental health condition. About 1 in 6 are reporting negative emotions all of the time or often. That's really high. And 64, more than 2/3 are feeling like, things are more stressful now. And I don't think the kids are wrong. I don't think that they're complaining. The world is different and it has different types of pressures. So what about the prevalence of substance use disorder and mental health? In particular, depressive disorder, which has a very high overlap. So about 40% of adolescents who present to you with substance use are also experiencing a major depressive episode or have major depression. So that's a high amount. And just knowing, the reason to me to know these stats is not just to do a webinar and throw out some statistics, but it's to say, I know 40%, there's a 40% overlap in this co-occurring disorder. That's a very high number. I need to be on the lookout and make sure that I'm assessing not just for mental health, but also for substance use and vice versa. Because nearly half of the 1 in 12 kids who have a substance use disorder have major depression. That's a huge amount. So we definitely have to watch for it, and we have to know how to assess for both. Here you can look a little bit by age group. Obviously, there's higher rates, percentages of youth who have substance use and mental health conditions in the 14 to 17-year-old group, but the 12 to 13, you can see, are still pretty high. The green bar is the amount where there is both disorders. The blue bar is the substance use, and the orange bar is the major depressive episode. So sometimes it's one disorder and not both, one or the other, and sometimes it's both. And there's definitely a higher likelihood of having both, a comorbid condition, as you get older. I think the important thing to remember about this, and I'll get to this again when we talk about assessment and screening, is that it's important to assess and screen for both. Because just treating the depression is not going to relieve the substance use disorder. They're two different conditions. And just because you're using substances to relax or to cope doesn't mean that that if you learned how to feel better, you wouldn't use that strategy. If it's come to the point where it is now at the level of a disorder, it needs its own treatment. And now you're doing kind of parallel integrated treatments because they are two disorders. And there's a danger if we kind of miss that. There's a danger of not treating the right thing. And actually, you could actually be medicating or treating the wrong thing. So one of the things we really have to learn is how do you do that kind of comorbid assessment and watch for both. And we'll come back to that a little bit. Lots of great comments here in the chat. I'm just glancing at them, but you're still putting in a lot of the stressors there. Okay. How many people here see adolescents? I mean, I assume everyone is seeing adolescents, but do you see adolescents? I'm not sure how to ask this question, so you can answer in the chat. Do you see more mental health, more pure substance use? Do you see the comorbidity? Maybe there's like three choices there. Like, I mostly see mental health and occasionally substance use. I mostly see comorbidity, or I mostly see more mental health conditions. So fair amount of comorbidity. Yeah, a little bit of both. A little bit of both. Yeah. Yeah, so this comorbidity, and if everyone here is trained as a mental health counselor, or those of you who are, you typically get less of the training on substance use. It might be in places where I teach, it's an elective, but it's not a core curriculum class in a lot of mental health counseling programs. If you went for if you're a substance use or addiction counselor, you obviously get very steeped in understanding substance use and addiction, but maybe a little less on the mental health. So, the fact that these two fields are so interrelated, and yet training still does have a little bit of a siloed. It kind of depends on where you go. I can see Lisa said it was a core curriculum in class for her. So it does depend where you go. It was never in my training many years ago. Addictions and substance use wasn't even offered. In the current places where I'm teaching, it is an elective. But it's not a core curriculum, and a lot of students take it because it's required on some licensing exams, but not for mental health counselors, but not for all states. So it's that kind of idea that it kind of depends on where you go and what you want to, and maybe you don't know what to look for. But the fact that it is so integrated makes me think, and it is in the DSM, that it should be more core. All right, I want to get to the meat of the issue here in thinking about how addiction develops and what it does to the adolescent brain and what kind of the dangers and risks are here. When I say that and think adolescent brain development and risk factors, if you could put a few ideas in the chat about what comes to your mind. What do you see, worry about, symptoms, concerns about what effect this might have? Or is it, I'm not sure, and you have questions. Any thoughts about this topic and what we're about to jump into? I'm kind of wondering, like, where do people sit in terms of knowing how it's affecting the brain? Any quick chat comments? It affects a lot of those things. You're talking about depression, which could be, is that an effect of substance use? Or is that a comorbid condition? This is where we have to get really particular, right? And really think about things. You're talking about some cognitive skills, decision-making, memory. You're talking about emotional factors, like I see motivation and impulsivity. Beverly's starting to get into the neurobiology. So prefrontal cortex, right? What effects does it have here? Emotionally stunted, that's an interesting word. I'm not sure exactly what you mean by that, because if what you're talking about is a failure to mature in the ability to self-regulate, that to me is how I would interpret that lack of emotional maturity. If we want to define that neurobiologically, we really want to think about, well, what is healthy development emotionally? And, the hallmark of resilience is to develop good emotional regulation and be able to use your cognitive skills to help manage and regulate your emotions, your prefrontal cortex to manage your limbic system. And that takes, for anyone out there who's parenting teens and young people, it takes 30 years for the brain to fully develop. So that negative, as Tristan is saying, that negative effect on the maturation of the brain absolutely is something that will happen. And we'll get specifically into how the brain actually is adapting to the drug use, because we're talking about the effects and the lack of maturation, but the brain will always adapt to the situation it is in. Classic concept of neuroplasticity. People know what neuroplasticity is out there? The fact that the brain will always be adapting to the experience. It's an experience-dependent growth process. The brain will not grow without experiences, starting from earliest years in life when you're parenting infants. So that infant brain cannot develop unless it has the experiences of relationships and safety, and it experiences emotion and co-regulation from another human being. It has to sense things. It has to have all this to grow. And we all do, right? That's how our brains mature. We experience things, our brain takes it in, it processes it, but the brain will adapt to that situation. I can see allowing new pathways to grow, destroying old pathways. So what you're getting at there, it's great stuff there, Tristan, is that the brain will adapt in this neuroplasticity, that it will adapt to whatever it's in, and that can be adaptive and that can be maladaptive. I think the developmental science is really at its, lots of interest in looking at how the brain is adapting to situations that actually are helping it be able to survive certain situations, doing things and adapting in ways that it allows it to function and survive in the environment that it's in. So there is an adaptive value to these changes that can happen. One of which is less about addiction, but I'll mention it here because of neuroplasticity. Put this up here for you. Is because this is what Tristan is saying, is that you're growing new cells, you're having neurogenesis, you can have new neuronal growth and form new gray matter and basically grow the brain with new experiences by enrichment and practicing activities, exercise. All of these things are great, learning for growing new brain cells, and you are forming or eliminating synapses, right? The connections between these neurons. Every time they fire, they're wiring up together and they're strengthening together. That's called Hebb's rule. And every time you're not using them, they're not firing, then they prune away and they get destroyed. And then the brain grows, it organizes itself based on the experience, it disorganizes, and then it reorganizes based on the experience it in. So you can see how it's very much a factor of adaptation constantly happening to the world that which we're in. And during our young years and our adolescent years, this is happening at a very high rate. It's the cortical restructuring of adolescence, which is triggered in a large part by puberty. But under adversity, under certain types of conditions, the brain is going to organize itself to adapt to those situations. And what I was going to say before was that they've been able to show, Dr. Nina Tottenham has been able to show how the brains of young children who are growing up under very neglectful situations, pretty severe neglect, their limbic systems, their amygdala will literally adapt to that situation of not getting their needs met and accelerate the maturation process. Now you think, wow, that might be a good thing. Their brain is growing up fast because they have a situation where they can't rely on adults, they got to rely on themselves. So the brain literally accelerates the growth process. And instead of staying as a young, emotionally reactive brain, which would be normal for a 6-year-old, that brain over matures itself to the point where it's not as reactive. And it looks more like the brain of a 15-year-old in terms of emotional reactivity. it's kind of dampened down the emotion, which might allow that young 6-year-old to survive and get her own needs met, but it will not allow her to retain that playful exuberance of childhood. And you all know those kids who seem like they lost their childhood and grew up too fast because of these situations. So this is what I mean by adaptation of the brain. It can adapt and change, even accelerate a growth process if the situation demands for it and is severe enough. And that adaptation sometimes can be a good thing, and obviously sometimes it might not be a good thing. That's the two-edged sword of neuroplasticity, which is a wonderful, characteristic of our brains, that it will always adapt and be plastic. And young children and adolescents have the most adaptive brains. This is the time of life where you have the most opportunity to make the most change because of where that brain is. And the reason I really harp on this is because in our next section, we'll talk about what drugs are doing to the brain. And when you think about drugs and alcohol changing the brain in ways that for such a young brain, that brain is starting to develop off track. And at some point, it's going to be very hard to get it back on track. Treatment is actually trying to do that, but prevention is the best medicine, and early intervention when the brain is still plastic and you can get it back on track. But that addiction goes on for so long, and now you're working with an adult who started when they were a teen. There are some places where it just can't get back to. It's always better with the brain to prevent and get in there early. So let's talk about adolescence and what's going on in adolescence, and then what happens with drug use. So in the chat, I would love for you to just put some thoughts. Let's just talk about teens. What's the essence of being a teen? What's good about being a teen? What's hard about being a teen for you? Like, what do you remember about being a teen? What do you think was good about it? What do you think was not good about it? If you were to capture in a few words in the chat, like, what is the essence of being an adolescent? Let's see what folks come up with. Lack of control, trying to fit in, peer pressure. I was so much more resilient. Interesting. Finding yourself, being understood. That's a lot of identity themes. Friends first, the impact of peers, right? Big expectations and responsibility. Learning, growing, sports, friends, all the fun stuff, the freedom, the independence, the wanting to do things, but yet the confusion, the risk. Risk is one of those, like, you're willing to try more things than you are when you get older, and at the same time you don't have the same great judgment, and so you might get in riskier situation. No worry of bills. I'm with you there, Laquille. Totally. The peer influences is really important too, because of what is going on. All of this is the essence of being a teen. And when I summarize it in one word, it's imbalance. It's just you're talking about all these great, wonderful things, and then all these really risky, tough things. And the brain itself, that kind of summarizes what's going on in the brain. This brain is reorganizing itself to the point where it is open to new experiences in ways that it may never be again, as we age and mature and kind of get a little more set in our ways. And so it's got great openness, great exploration, great willingness to take chances and try new things. And at the same time, it is highly vulnerable to stress and external influences. There are parts of the brain, in particular the insula, just like kind of think about it like your third eye, the part that helps you look inside and figure yourself out and kind of, have a little insight. During adolescence, the insula is like hyperactive. It kind of turns on very, very strongly. And so there's a lot of that looking in, which is why we are finding ourselves and trying on new identities and changing our hair all the time and doing all kinds of things to figure ourselves out. There's a lot of introspection going on. That's a wonderful quality, right? It allows for identity exploration and identity development. It also can open you up for rumination and constant comparison of yourself to other people. So you can see that double-edged sword of some of these kind of the way the brain is operating in adolescence that simultaneously could put you at more risk if you don't have the other protective factors around you, like healthy communities and healthy schools and healthy families and things like that. So that's kind of one of those areas. One of the other areas in our limbic system is the HPA axis, right? So we've talked about how this is a wave of cerebral restructuring. The first wave is happening when we're 0 to 5. That's our first kind of structuring of the brain. And then we kind of settle and we grow our brains. And then adolescence hits with puberty and we have a second wave of restructuring that's happening. So the two biggest times of neuroplasticity are happening at that age group. But puberty has reproductive hormones have a strong effect on the brain structure and on the brain systems, meaning the nervous systems. And so certain neural networks become very sensitized to the activating effects of these hormones. During these times, the neurotransmitters, there might be changes in the neurotransmitter systems. That's why adolescents might respond to a medication differently than an adult. And might be more at risk for like suicidal ideation under certain medications because the reproductive hormones and the neurotransmitters are interacting in a certain way. Obviously, synapses are eliminated as we're restructuring, but there are very gender-specific impacts on the HPA axis. And I'd probably say sex-specific because what I'm talking about here is biological sex in terms of hormones, meaning testosterone versus estrogen. So the HPA axis, hypothalamus, pituitary, adrenal gland, is the core axis that kind of is in your stress response system. When your amygdala goes off, and I know everyone knows the amygdala have that kind of reaction to something scary, it triggers the HPA axis to turn on. And so your hypothalamus sends a message to your pituitary gland, which releases certain types of hormones, and then down to your adrenal glands, which releases adrenaline. Now you have your stress response turned on. Obviously, this same response is hijacked in trauma when that HPA axis is so dysregulated that's happening too much. But during puberty, what we know about the interaction between reproductive hormones and the HPA axis is that testosterone is rather protective. And so it kind of protects the HPA axis from being too reactive to stress. And estrogen excites the HPA axis and kind of makes it more reactive to stress. So you see those differences in adolescent males and adolescent females when estrogen levels and testosterone levels are really peaking and they're not yet in balance yet. That there's a theory of maybe there's some connection there with why adolescent females might have higher prevalences of certain mental health disorders or emotional reactivity during that time because of estrogen and how it's having this impact on the HPA axis. So all of this stuff is going on inside adolescence. And we haven't even gotten to drugs yet and alcohol, but this is the basis. This is what's happening just at its base. Just imagine pouring some alcohol on that and what that's going to do. So we know that brain structure changes naturally. We prune away gray matter, we increase white matter, we form synapses, we get rid of synapses, we have heightened activity in the limbic system, we're more reactive to stress, especially if you have high levels of estrogen, and you have anticipation, you have a more active insula process where you're much more kind of like introspective in not always the healthiest ways, but kind of like really looking at yourself constantly and maybe a little self-comparison going on. And you have a heightened reward system. Now go back to what you said in the chat about social media. Anticipation of reward is what gives us dopamine. And we all know dopamine is that kind of pleasure neurotransmitter. I think there's a lot of books out there in media like the Dopamine Nation, and we're all chasing our dopamine hits and things like that. And what gives us dopamine? Lots of things do, things that make you feel good. It's really the anticipation of the sense that that thing's going to feel good that then helps you feel the reward of that, but it is our reward system, which is part of our limbic system. I can't touch it. It's in the middle, but there. The ventral tegmental area, VTA system, and the nucleus accumbens is the place where that's affected by the dopamine, right? That's where the receptors are. And so you're releasing and catching dopamine in those areas, and you're releasing high levels of dopamine. That section of the brain is more activated in adolescence as compared to children and adults. Super important understanding of science and why certain things put teenagers at risk more than others. Because the idea that something's going to be pleasurable and experiencing that high level of dopamine places them at an unusually high risk to get addicted to something, to whether it's drugs, alcohol, or any of the other kind of behavioral addictions. What you guys just all put in there, social media. I mean, from what I understand, I think it's Instagram and YouTube are like two of the worst offenders in terms of the algorithms that create the likes, that create an impact on the reward system. And certainly people are suing and trying to prove that, we literally are placing our teens at risk. And these are teen brains. I'm not talking about even young adult brains where the system starts to wane a little bit. TikTok, absolutely. But anything that's going to release dopamine into that part of the brain, you are more susceptible to. And you're also more susceptible to peer influences. So think about all the things that are affecting our teens. Drugs and alcohol are one of the many things that activate these systems and heighten it up there. And the difference with drugs and alcohol than, say, social media, though I'm not sure if we have the exact numbers on social media, is that usually a chemical releases like 12 times more dopamine than like a behavior. Exercise makes you feel good. Going out with friends and having a social conversation makes you feel good. You get dopamine hits from that. But taking cocaine, 10 times as much dopamine. So the addictive power of the drug is very, very powerful. And it's not to say that the positive kind of healthy behaviorals aren't giving you that, but the amount of it is so much greater when it comes to a chemical. So we wonder, why do they do what they do? Well, it's because of this imbalance. They have high plasticity. Their brain is open to environmental influences in a way that is unlike any other stage of development, that have extremely strong effects on the cortical circuitry. It's hypersensitive. It can kind of activate and amplify. It can release more levels of dopamine. Once those things start to happen, the brain starts to develop in that way. And you keep doing those things, now you have a brain that's becoming more and more and more sensitive and looking for those experiences. So the door is now open to harm if we are not careful. I mentioned before that this imbalance in the limbic system and the reward system that happens, also there's also a heightened sensitivity to peers, right? And that's normal. Like, this is a time when you're, psychologically speaking, moving away from, authority. You're moving away from parents or caregivers. You're trying to establish yourself. Your peers become a huge influence in your life. So on a social development, that makes sense. But on a cognitive development, it also shows that during this time period, during the younger years of adolescence, we lose our ability to make good judgments in the presence of our peer group, because the peer group kind of overrides our normally good cognition. And I'm going to explain this graph for you in 1 second, but what we know from this particular study and some others is that by age 15, adolescents have developed a very strong cortex. Of course, they're still learning and stuff, but take them out of their situations with their friends and ask them to make decisions about things. They normally could make decisions, and they do it by being able to, just like adults, not just follow the rules of like, okay, well, if I need to decide this, I should do this and then this, because this is kind of what the rule of the game is here. But also by being able to take into account the perspective of other people, which is an empathy skill, right? So I'm not just following rules of what to do, but I'm kind of also interpreting how would my behavior, how would this action that I do affect someone else? What would they think about it? And that information gets put into the pool, and I'm able to make a very good decision based on cognitive, fact-based rules and the impact perspective of others. So I'm putting those two things together. And I have the capacity, the brain capacity is there to be able to do those things. But when you put that same age adolescent in a group with peers, the capacity to take in the perspective of others kind of goes out the window. And you start to only just be able to apply the rule because the emotional brain, right? The emotional brain, which is so not fully developed yet, still got 15 years more to develop, is so highly sensitized because of its stage of development that all that dopamine and sensitivity to things and kind of worry about comparison kind of overrides your normal cognitive thought process and being able to consider all these different perspectives. And what do you end up with? An emotional brain that says, don't worry about what your parents think, just do it. Do it. Your friends will like you if you just do it. That's your emotional brain just kind of knocking out your normal ability. So when you go back to the why do they do that, it's because of this process, because of the context that they're in. Sometimes they're going to make really good decisions and you know that they're perfectly capable. And other times you're like banging your head against the wall and saying, why? Why? You know better. They do know better. But in this situation, they're highly influenced, which is why you have public health safety rules about not having too many adolescents in a car at once or, needing to have an adult with you at a certain age. You're trying to minimize the impact of those external influences on decision making among teens. And you can see from this study and this chart that when teenagers are alone, ages 13 to 16, 18 to 22, they have about the same rate of making a risky move, making a bad decision. It's not terribly high, and it's not all that different. So, even 14-year-olds and 20-year-olds have the capacity to make good judgments when they're alone. Obviously, the 24 plus, this is where it's like the lowest amount of risky behaviors. Not that you don't take risks, but you have the judgment to stop yourself much better. The problem becomes when you are with peers, right? And when you're with peers, see how much higher the 13 to 16-year-olds are in terms of making a risky decision versus the 18 to 22-year-olds. And then the 24-year-olds, really, there's not that much change between being alone or being with peers. That means the brain has matured emotionally to the point where your emotional brain isn't constantly overriding your common sense. But it happens still for the 18 to 22-year-olds, not as much, but it's the 13 to 16-year-olds that are the most at risk. And it's because their brain isn't mature. And so this is kind of the situation that we have. And then consider addiction, consider substance use, consider peer pressure, and all the things that you're talking about, that alcohol, being exposed, being at a party where everyone's smoking or everyone's having a drink in their hand and you don't want to, but you don't know how to deal with that in that situation. And then you're so vulnerable to that pressure. This is the group where we've got to figure out ways to help them know how to manage that, because this is also the group where if they start early, they're at most risk for having the worst outcomes because their brain is just that fragile and it's going to change in all the ways that we don't want it to change. Thank you, Tristan, for sharing some of that information there. Okay, so let's talk about addiction and how it develops so we can get to some treatment ideas here. So what we know at its core for addiction is that it's a neural adaptation process. The brain is becoming more and more adapted to the substance that it's taking. And it doesn't, this is true for any substance, whether you're talking about caffeine and how much caffeine do you have, versus, a really hardcore, maybe cocaine or heroin or some or alcohol, some other kind of substance. So it really is this process where there's a tolerance that there's an experimentation phase, there's a trial where it's just normal. But then there is something that happens where the brain starts to tolerate it more and more. And then it becomes to the point where it's craving it, wanting the dopamine, and now it's dependent on it. And that's when you're at those stages of more severe disorders that have withdrawal. So what starts as pleasurable experimentation, usually voluntary, nothing unusual about that, over time might start to become a bit of a habit, just something you're doing out of habit, but you're not yet at the place of having built up tolerance and dependence, right? You are in the early stages. Even coping, I'm just using it to sleep. I'm just using it to relax at the end of the day. But there isn't that dependence yet. There isn't that kind of constant craving for it yet. The brain hasn't kind of switched over into this place where it now needs more and more and more to feel the same way. That's the place where you have built up tolerance and the brain has now shifted. It's changed. But there's this kind of ramp up before the brain actually gets there. And that depends, how fast you get there depends on who you are, your genetics, your risk factors, how much you're using, of course. But in those first couple of steps, if you are identifying these issues in mental health treatment, in mental health treatment, or in being able to see kids in school settings or community settings, you're at the early stages. And these are the stages that we want to get in on, to where really in early intervention and prevention. And a lot can be done at that stage, because once we get past that and we get down into a compulsion and a craving and a dependence, we end in despair. What was once pleasurable is no longer a pleasure. So the way I present and think about addiction, and I think where the science is, and tell me if you disagree with this, is that it is a neurobiological disorder. It is not a disorder of character, of willpower, of choice, but at its core, a full-blown addiction is a neurological brain. It's a brain disease. The brain has changed. And ultimately, we are now working with a brain that has changed in ways that it may go back in certain ways and it may not. Lisa, I see you agree with that. Tell me if you think that the culture agrees with this. Does the culture see addiction as a neurobiological disorder, which thus needs a particular treatment? Or do you think the culture, our culture, I'm talking about American culture, doesn't see it as a brain disease, sees it as something else? A lot of people would say that it depends on where you are. Some people will, I think the science is very clear. But I think depending on belief systems and culture, and where you are in our big country here, there's a long history of seeing this as a choice, as something that you're just choosing to do. So I do think that we're catching up, but I do think there is an incredible amount of stigma still out there that keeps people from coming in. Most people don't get treatment, even with that high prevalence rate. I think it's like 7% actually do get treatment. The younger you start, the higher the risk. Plain and simple. And that younger start has to do with everything we just talked about in terms of the brain, that we're putting that very open, receptive, changing brain that is sensitive in so many, unique ways at that stage of development. We're putting it right out there with a massive risk factor that's going to change it. There's a strong genetic component. We do know, you can see there's a study from the University of Utah that talks about a dopamine receptor gene that's more common in addicted people to alcohol, cocaine and opioids, and that there's variation in many people in terms of how drugs influence the reward pathway. So it's not like a one size fits all, but there are some genetic components there. And then there are all the psychological and adverse community risk factors, from parenting and community to adverse childhood experiences, abuse, neglect, discrimination, oppression, look, all those kind of factors on top of it. But when I hear that someone started young and they're continuing, I'm quite worried, for sure. Trauma, of course, yes, very big risk factor. So how does it change? What do I mean about what it's doing to the brain in a way that at some point becomes very difficult to reverse? So when a person uses a substance, all substances will change the brain. Period. Doesn't matter what it is, whether it's sugar, caffeine. I've got my M&Ms and my Diet Coke over here, and I'm like sitting. I always do these trainings, and I'm like, yeah, my sugar and my Diet Coke. Yes, I have it. So I'm having a fun time on the webinar, but they're hard to give up. They have quite a power over me, my M&Ms and Diet Coke. And that is a very strong influence, right? Thank you, Consuela. You're not shaming me. Thank you very much. But I'm very aware that I don't normally have this because I like it so much that it makes me want more. And it will not take long before I'm having it all the time. So, as an adult, I have to say, it's more of a abstinence approach. I try not to have it because it's very hard to just have one. Harm reduction in M&Ms doesn't work so well. So why is this? What's happening? And when a person takes a substance, be it M&Ms and sugar, or be it alcohol or cocaine or something, the A process is what happens when you experience the dopamine release. It's called the A process. This is Judith Grizzle's work, which I like. And whatever the drug is meant to do, if it's alcohol, it's meant to sedate me. If it's cocaine, it's meant to bring me up, right? Whatever the drug is meant to do, that is I get the pleasure from it, the dopamine release, and the drug has the effect on the brain of doing the thing that chemically is meant to do. Sedation, activation, whatever. In response, the brain will always do the opposite of what the drug is trying to do. Always. And the reason that's called the B process. So the reason it's meant to do that is because your brain wants to get back into homeostasis. It wants to get back to balance, right? And so if I created an A process with my M&Ms and I went up, then the brain naturally starts to do things to try and bring it back down because it wants to be back in balance in homeostasis. So the brain will always eventually do the opposite of the initial response of the chemical that you take. Natural response there, trying to get back to a normal state of being. It's very good at doing this. We're very, very good at getting back to our normal state. The problem is, over time, if you keep doing that thing, it will take more and more of that thing to feel the benefit of the A process. Eventually you don't enjoy it anymore. That is the essence of the development of addiction from a neurobiological process, not from I'm using it more and more for coping, I'm making bad decisions. That's all true. That's coping skills, that's psychological stuff. But from a neurobiological perspective, there's a shift in the A and B process that's happening. So if you look at this, you see that A state in the initial effect, right? And I go up, I feel good. I'm having a nice long enjoyment of the A state. And then at some point, the brain has kind of figured out, it turns it and says, we got to get back to homeostasis. So it gets me back down in the B state. And I'm saying up and down just because of the graph, but the A state could be sedation and the B state could be getting more alert again. So, make sure you're thinking about that in various ways. But you see how long the A state is, and then eventually you have a B state, and the B state doesn't last that long. It's kind of like the crash after a cocaine hit or ecstasy or a drug that brings you very, very far up, oftentimes people feel a little depressed afterward, and then it evens out, right? That's kind of the A and B process that you can think about. Nicotine might make, or alcohol might make you feel sedated and kind of calm, but you might actually afterwards start feeling awful and a little agitated and restless as you're sort of getting back up there until you even out again. Same with benzodiazepines and anti-anxiety meds. They might calm you and sedate you at first, but then they have the opposite effect. If you stay on them too long and you become addicted, it has the opposite effect of having, I mean, they always have the opposite effect of bringing you back up again. But over time, what you'll see here is that, see here how the A process doesn't last very long? You've used so much that the A process is a very, very small little hit, and it barely lasts. And your B process, which is the bad part, the opposite effect of the drug, not only is it deeper and more intense, but it's lasting longer. That is tolerance. And when you're there, you're in withdrawal. If you stop doing right there, then you're going to feel this longer and more periods of time, and it's going to feel terrible. If people understood this and how this very simple thing happens in the brain, I don't know if teens would use this information to prevent. I'm not sure that they would, because none of us are very good at just taking information and stopping doing something bad for us, and especially teens. But it certainly, for me, gives me a little more empathy. If you're working with someone where it's like, or you even have a family member and you're like, why won't they just stop? Like, just stop. And it's kind of like the just say no, that doesn't work, right? You're telling this brain that's in this state that is becoming more and more of a B brain than an A brain, you're telling this brain to just stop, when neurobiologically, it is not programmed to do that. It is programmed right now to be more in pain than in pleasure. And we will seek to relieve pain any way we can. That's the essence of what an addiction is at a neurobiological level. All of that happening at a young age, because of the age of onset, the being trauma issues, social media, the influences that are happening. Maybe you're in a family where there's substance use. All the risk factors are playing into how quickly that A process will turn into a B process. And when you have kids with all of these issues going on and they're using, they are at super high risk for a very quick shift from an A process to a B process. Because if they use enough, there's no doubt that the brain changes. Now, when your brain is in that state, it will be very hard to go back. The questions become, how do you treat them and what form do you use? But substance use will always trigger changes in the structure of the brain, and structure dictates function. If the brain changes in its structure, if there's less gray matter, if there's less connections, if the connections you're pruning away are the healthy coping skill ones because you're not using them, and the ones you are using are the behaviors that allow you to get that drug and figure out what you're going to do and maybe manipulate and do the things you need to do, that part of the brain is going to get stronger. The part of the brain that allows you to think and learn and go to school is going to get weaker. You got a brain that is now changed. And that is the child that you are working with. And that is the treatment that you're providing to do whatever you can to get as much of that brain back to a typical place as possible. Because otherwise the problem just worsens and worsens. If we can delay use till that brain is more mature, at a minimum, post age 16, better after 22, the level of risk that we do to decrease the level of risk to the brain is substantial. This is for marijuana use, this is for anything. The question is, how do we do that, right? How do we work with teens to delay it? What are some of the strategies that are out there? Basically, doing some evidence-based screening and assessment is where you start. You got to know what you're working with, right? That's number one. You have to screen early. Screening is not assessment, right? Screening is really about identifying as early as we can anyone who might be at risk. It's all about knowing the risk factors. The more you understand the risk factors, the more you can screen while you're just sitting there talking to a kid because you're tacking them up in your head, right? Assessment is the bigger picture, and then treatment. Um, Treating the underlying substance use disorder does not always relieve the mental health issue. Treating the mental health issue does not always relieve the substance use disorder. If they are comorbid, you need integrated treatment. No two ways around that. That it is most effective when substance use is seen as primary and comorbid with a mental health disorder and is not just treated as a fallout or something as related to this other thing that, oh, because you did this, then this substance use happened. But once we address this, the substance use will go away. That's a fallout. And that's a fallacy. If it's at the level of a substance use issue, you have to think about integrated treatment. And integrated treatment is assessment for comorbidity, considering the interaction, and treatment based on priorities, always starting with safety and learning how to make good, safe decisions. That's early recovery from anything is safety. Stabilization is your next phase is, okay, how do we start doing some new things while not disrupting my stability? And the deeper psychological work, the trauma work that you might want to do where you're talking about, memories and things, you got to put that on the back burner until both disorders are stable, whether it's a trauma disorder and a substance use disorder. Because if you start doing too much too soon, you are no longer in stabilization and safety. And stabilization and safety can go on for a very, very long time. It's not sexy work. It's not, fun work, maybe. It's not this big uncovering kind of work and the deep psychological stuff. It is the work. It is the most important thing you can do to help someone. Screening for the level of use and the severity of use. Figure out where on the continuum they are. Included in a general psychosocial assessment that looks at all the factors and co-occurring disorders so that you can figure out how these things align. One of the best tools you can use is a timeline. That you're getting a substance use timeline. When did things start? When did they escalate? When did you try something new? When did you relapse? When did you go into services? Create a timeline. And then under that, create a timeline of mental health and life factors. First episode of something, broke up with my girlfriend, lost my parent, major issue over here. And then you start to look to see if things lined up. It's a very concrete tool to do comorbidity, to look for patterns, to see, is there a relationship between these two things? How are they playing out? And how have they developed? What's the course so you can plan to match the treatment? The screening method of ESPERT, which many people might know, is to screen, provide a brief intervention, and refer to treatment if necessary. And screening is really about, are they at low or no use for alcohol or drugs? Are they at moderate or medium they're in harmful, but not yet fully hazardous places where they haven't had the big consequences, but they are using. And so you're kind of in that risky range, or they're significant. And if you screen someone using evidence-based screening tools like the audit and the DAST for alcohol and drugs, the CRAFT for teenagers for alcohol use, there's lots of them out there, but those are the ones I favor. If there's low use and they're really not using much, then you are just supporting, monitoring, providing positive feedback that they're making good choices. If you're in that middle area where they're not yet in those way down the road places, but they're using enough where we know where the course of treatment goes, the brief intervention is psychoed. It's explaining, if you continue, here's some things that can happen. Here's some things you can do. Here's some things we can do if you want, right? It's kind of a brief intervention using motivational interviewing strategies to see if you can kind of get people to want to engage in kind of early to preventative to early type services. And the readiness ruler is a really good strategy there where, on a scale of 1 to 10, how motivated would you be to maybe cut down on your drinking or give up drinking, depending on the age of the person you're talking with and what you recommend. And if someone says, well, maybe a 5, so they're kind of they're a little motivated, but not very, that tells you where they're at and what you're working with. And then if you ask, why didn't you pick 2? By asking that question, you're getting them to verbalize what it is that's motivating them at the 5 level. And they say, well, I play soccer and I want to be good on the team. So I don't really I don't want to screw up. I want to be good on my team. And so now you have your motivator. Okay, so you really want to be a good athlete. So to be a good athlete, these things can get in the way. I wonder if you want to come back next week and talk some more about figuring out what we can do so you can stay a good athlete and maybe become a better one. Now you've identified the motivating factor just by doing that brief intervention. So SBIRT is your first step into screening and understanding where someone's at. If you are working with them ongoing, you're doing kind of an assessment to figure out the co-occurring disorder. And that's your normal mental health assessment. Because the reason is if we miss a co-occurring disorder, we could be treating the wrong thing. And substance use treatment might be incomplete if we only diagnose depression, but there was a substance use disorder, which happens frequently. When like the kid I mentioned at the beginning who had psychosis from cannabis, if I hadn't asked the cannabis questions, and I actually did a DAST on him, so I did a screening, turned out he was smoking a lot of cannabis for a long time, a couple of years. And he had his first episode psychosis somewhere between 16 and 17. He was seeing triangles everywhere. That was his first episode. He was just having visual hallucinations, and it really freaked him out. But because of his adopted biological history, people got worried about schizophrenia. But if I hadn't asked that and we only treated him for depression and maybe depression with psychosis, oh my God, we could have given him the wrong meds. We could have been treating him for the wrong thing when all along it was cannabis. So it really is about complete treatment and not assuming that something doesn't exist just because they didn't present it up front. So in our assessment process, we start with our screening process, our SBIRT. You integrate assessment and doing some substance use assessments with these screening tools, and I would strongly recommend you use them because in substance use assessment, we need to ask very specific questions about use, and using those tools helps you rate where someone falls. So definitely have them in your arsenal of toolbox there. There's no one way. You might do it at the start of every intake because it's what you do. You might integrate it 3 sessions in because it kind of came up and there's a risk factor and it makes sense to integrate it. There's no right way. It's what fits, right? But you explore the substance use related questions. You do your timelines. You figure out what's going on and why. And you formulate like what you think is going on so that you can make a treatment plan. When it comes to treatment, we need to do a number of things. We need to educate constantly because we're up against cultural myths and social media that says one thing or another thing. We're up against inaccurate information that's out there and a lack of information, particularly about the brain. Even though there's a lack of information about the brain, people are very interested. It's the one topic where I find a lot of people grab onto it and want to know more. So not only are we educating youth, but we're educating families. And we have to work together. If we're going to work with youth who have substance use, you cannot do that without working with families. Because there's always a family dynamic happening that may be supporting the use or underlying the use in some way. But we have to be able to integrate those. Engaging in a discussion and a partnership about what's going to work for them so that you can balance that. Coming at someone from the perspective of you have to do this or we need to do this, or if you don't stop this, then I can't see you. This is not motivational interviewing strategies, right? We need to be able to engage in motivational interviewing, which means taking a step back and figuring out where people are, what's motivating for them, what they feel like they can and cannot do, what they're willing to do, and working with that as opposed to trying to push it, because otherwise all we're doing is we're creating resistance. And if anyone comes up against you, your first response is to push back. And that's heightened for adolescents, right? Naturally, just because of their stage of development. So the last thing you want to do is set up that dynamic. So if you haven't done MI training, if you don't have MI skills, that's your next training. That's where you want to go, and you want to really hone in on MI skills. Our 4 essential domains of substance use treatment is what to prioritize. So you've done this assessment, you've screened, you've done an assessment, you know where they are, and you're trying to prioritize treatment goals. And that really is going to depend on what you find, right? How severe the depression is, how severe the substance use is, what type of substance use, where things are at, what kind of decisions are people making? Are they at the severe level, or are they at the mild level on the DSM category? And so what's the priority here? Is it psychoed? Is it harm reduction? Is it abstinence? These are choices. And one of the conversations to be had is, do you have a bias towards one or the other? Do you have a bias towards abstinence? Do you have a bias towards harm reduction? Do you prefer one method over the other to reduce harm by having people just slowly cut back versus giving it up completely? With teenagers who are underage, sometimes it's really hard to do harm reduction because you're like almost saying it's okay for someone where legally or their age-wise, it's not. But at the same time, abstinence might push someone away. So with adults, I think there's a choice about abstinence and harm reduction. With teens, it's complicated. And it has to be a real discussion. And certainly with young teens, I don't think it's a choice at that point. So you're thinking about things in all these ways. You're thinking about involving significant others and support groups. Peer support is a mainstay of addiction treatment. Peer support for teens. Making sure you're not the only person trying to provide that support. Engaging significant others, making it something that is a family, so that there's more people being able to support that teen in making good decisions as the pressures come up and they're faced with conflicts, and constantly monitoring and figuring out how they do. And that is what I often say is a little bit more direct than sometimes typical mental health counseling, because it needs to be a bit directive. Like, you need to not be afraid to ask the really direct questions, and being able to, ask directly. Did you drink at the party? Well, I just one. Well, just one what? Did they just have one keg of beer? Did they just have one little sip of a 5-ounce glass? Right? Just one glass of wine? Well, is a glass of wine 5 ounces, or is it one of those giant little, 12-ounce kind of fish bowls that people have these days? One of what? You have to be specific when it comes to this. The problems arise in treatment when you can overemphasize substance use because you're so worried about it. This is like our countertransference stuff, but you overemphasize it and it's a low priority on there. So you're mismatching, you're not fitting yourself with the client. You've got to find a way to fit. You underemphasize it and you're missing the signs. And then you leave the client feeling very unsupported, because deep down inside, people are getting help often. And as much as you're saying, I don't want to, they don't want to be found out, as much as they're saying that, people want help. And so you're having to manage that ambivalence. Ambivalence is the crux of treatment, right? Moving, managing, working with ambivalence, using all of these kind of motivational strategies. If you don't explore that ambivalence, if you push too much, you might silence people, you might push people away, or you might collude and engage in the denial that's part of the disease. And if you don't explore how their life is going, so how does substance use fit in? It is not all about substance use, it's about how it fits into your life. You have to be able to address relapse and recurrence, understand what relapse is or recurrence is, understand the steps, understand the warning signs, have a relapse or recurrence plan where you list out warning signs, you list out strategies, you list out people and phone numbers about what you're going to do if these warning signs come up. You get concrete in creating these behavioral plans, relapse plans, and have it so that it's practiced. Oftentimes, what you'll do in a session is do a role play. What's going to happen at the party you're going to go to when someone comes up to you. And if you do these role plays where you play the client, you can do it in two ways. You can play the client going along with the pressure, and then you talk about what that was like. And then you can play the client, role play for the client how to handle the pressure, and then have them do it. So you're constantly switching roles, putting yourself back and forth in different roles to play out the very pressures that they're going to do when they're out there, right? And understanding that one lapse does not inevitably lead to a full-blown recurrence, but there are very early signs that could be building up for months before you get to it. And, it's not that you're getting to a recurrence is one event. That recurrence is many events. It's a journey. And you have to understand recurrence is not a time thing, but there's a process happening before it. You want to gauge in the process and work in the process as it's building up to a major kind of use happening. Lots of best practices out there that you can use. These are the ones that I think are pretty well known and established. Obviously, multi-dimensional family therapy. CRAFT is great, community reinforcement and family training. It's probably one of my favorites. And the adolescent version of that, I would recommend that very, very, very highly. You can just get that information from evidence-based treatment strategies. You can get the manual, really read about the model for it, and they're very, very strong. There's relapse prevention, there's mindfulness, which has really good effects, as well as the strong African American families one. These are some real highlights. Seeking Safety is a nice model. If anyone's used it for trauma, it's a workbook and you've got all kinds of different things. It's much better, and the evidence for it is good for reducing trauma symptoms. There's no effectiveness seen for reducing substance use because it's really geared towards trauma, but it's a nice add-on to do with other things because it's all kind of about making safe decisions. But on its own, it's not like substance use treatment. You want to pair it with something else. So I will end with just some final thoughts about youth. Youth's identities are shifting, right? Young people have kind of mantras, they have ways of talking that can focus on negative things, but can focus on positive things. And so we're changing our identity, and in more of a psychological term, as you're going into recovery, as you're working with teens, you're moving from an identity of someone who maybe sees themselves as addict, or hasn't identified that way, then identified that way, and now needs to identify as someone where that was part of who they were, their recovery identity, but it's not all of who they are. And in teens, that identity growth and development is super important. So figuring out what's your purpose, who you are, narrating your story, creating a new self-narrative as you're moving through all the technical parts of this treatment is super hard. And recognizing that they are worth what comes with recovery. They are worth it. Thank you very much for your time today.
Thank you so much, Carmela. Lots of great feedback in the chat from you. We do have a couple questions in the Q&A, but I do know that we are close to our end of time, so I will capture those questions in the Q&A and send them to you if you would be so kind to answer them, and then I can share it out with the group who attended today. And then I did put some reminders in the chat. Just please make sure that you complete that post-event survey. Your feedback is greatly, greatly appreciated. We do review it all, and it does allow us to continue to provide free trainings to you all. So your feedback is very, very important. I just put the information in the chat again. The recording and the slides will be available on the website as soon as possible. So once we close today's session, I will start processing that recording. And then we are this was session 1 of our I'm Still Standing Transforming Youth Substance Use Care in the Midwest webinar series. So thank you so much for Carmela for being a part of our kickoff session today. And then session 2 does take place next week, February 20th. So please make sure if you enjoyed today's session that you register for February 20th's training.
Bye, everyone.
Thank you all
Be
for being
well.
here.